So we're going to continue our Mrcp basis consultation station, and today I'm going to talk a bit about polymyositis. So let's start our presentation. So as we are discussing this case in our consultation station, so we'll start with the history. So this is a 39-year-old female, and she presents with a 2-week history of progressive weakness and myalgias, which are affecting her arms and legs. She is normally fit and active, but is now tiring easily and feels breathless on exertion. And she also reports painful hands and her fingers changing color in the cold weather, but no rash or other symptoms of connective tissue disease. Now, remember this polymyositis, it is one of the conditions which is described under the umbrella term of idiopathic inflammatory myopathies. And it has a peak age of onset between the ages of 30 and 60, and women are actually 2 to 3 times more likely to be affected than men. So the onset of symptoms in patients with polymyositis is variable, and patients usually present acutely or subacutely. However, symptoms initially they may fluctuate episodically, or in some cases they may gradually progress. And remember that weakness, it is the most common feature of polymyositis, and it is associated with muscle pain in around half of the patients. While remember, these symptoms suggest pathology at the level of the muscle, and there is a broad range of differential diagnosis to be considered, like inflammatory myositis, infectious myositis, rhabdomyolysis, metabolic or endocrine derangements, some of the drugs or toxins, and congenital myopathies. So whenever there is a weakness, should also prompt consideration of neuromuscular and neurological causes as well, particularly if we don't, if there is an absence of elevated CK level, or we have other objective evidence of muscle disease. And remember that if there is a symmetrical and proximal limb muscle weakness, it is the typical distribution of polymyositis as well as dermatomyositis. And the pelvic and shoulder girdles are the sites which are most commonly affected. In comparison to this, if there is an inclusion body myositis, it has a more, in this, the knee extensors and the finger flexors are mainly affected. So remember that if the patient is young and fit and active, these patients have significant reserves, and therefore even if there is a mild degree of weakness, it should be taken seriously, and it likely suggests significant pathology. So any recent changes in the physical activity or preceding heavy exercise is also relevant history, and this may be a trigger for rhabdomyolysis. So while we're taking the history, we should inquire about the reason for the patient's easy fatigability. Possibilities may be exercise limitation due to pain, weakness, or breathlessness, generalized lethargy, or maybe the combination of the factors. So quantifying the exercise tolerance is useful actually in judging the severity and impact of the disease. So exertional dyspnea is a concerning feature in this patient, and one which warrants urgent retention. So it may signify either respiratory muscle weakness with the risk of respiratory failure, cardiac muscle involvement, interstitial lung disease, or pulmonary hypertension. So another important point is the nature of the painful hand should be explored further. We should ask about symptoms suggestive of an inflammatory arthritis, such as joint pain, which is worsened in the morning and better with movement, with associated stiffness. Pain may also result from ischemia, as occurs with Raynaud's, or it can be painful peripheral neuropathy. So in this patient, this change in color in cold weather is suspicious for Raynaud's phenomena and should be clarified further. And you know that this Raynaud's phenomena, this occurs due to peripheral digital ischemia from vasospasm of the digital arteries and arterioles, It may be primary or secondary to other diseases like connective tissue diseases. And there are three phases. We have pallor, cyanosis, and then erythema. And it occurs because of the reactive hyperemia. So she has otherwise been in good health recently and does not take any regular medication, and she has no relevant family history. So remember that a number of rashes may occur with an inflammatory myositis. So dermatomyositis has pathognomic cutaneous features, and idiopathic inflammatory myopathies can also occur as an overlap syndrome with lupus or scleroderma, and which have their own characteristic skin changes. So when you say connective tissue disorder, disease is actually umbrella term and encompass a range of related multisystem disorders. Connective tissue diseases, as we know, these are rheumatoid arthritis, SLE, polymyositis, and dermatomyositis, scleroderma, Sjogren syndromes, mixed connective tissue disease, and undifferentiated connective tissue disease. So it is also important, remember, to identify symptoms that may suggest muscle involvement beyond the limbs alone. These include truncal weakness, facial weakness, or abnormalities of speech or swallow, respiratory weakness, and cardiac dysfunctions. Relevant illnesses include anything that may predispose to secondary causes of muscle dysfunction, infections which can induce myositis like influenza, enterovirus, toxoplasmosis, malignancy due to association of myositis with paraneoplastic syndrome, or prodromal extramuscular symptoms that may be part of systemic disease with muscular involvement like vasculitis. Family history is important. It may point to rare hereditary syndromes such as metabolic myopathies, mitochondrial myopathies, and muscular dystrophies. A drug history is important because it may identify agents which are associated with muscle disease like statin. It can cause a wide range of muscular pathology ranging from simple myalgias. Simple myalgia means there is a pain but there is no CK elevation. It can then another stage is myositis. In this way there is CK elevation, and rhabdomyolysis, which has CK elevation as well as myoglobinuria or renal impairment. And finally, the worst scenario is necrotizing myopathy, and this is actually an immune-mediated myopathy, does not improve with cessation of statins and requires treatment with immunosuppression. So this is all about the history. I think I've covered all the salient points which we must ask about this patient who is presented with some muscle pain and weakness. Let's move on to the examination now. So this patient is afebrile and respiratory vital signs are normal. Muscle power is graded at 4+ in the proximal upper and lower limbs but normal elsewhere. There is no rash on close examination of the knuckles, eyelids, and other sides. However, there is some thickening, roughness, and fissuring of the hand, especially over the lateral aspect of her fingers. There is mild synovitis of the wrist and hand joints. Examination of the respiratory system identifies fine bibasal crackles and normal chest examination, and there are no signs of pulmonary hypertension. So remember that we should ask about actually examine the patient for the fever, because fever can be a systemic feature of inflammatory myositis, particularly subtypes with more acute onset and rapid progression. We should know about we can count the respiratory rate, and oxygen saturation is also important because it can be abnormal if there is severe compromise. However, these are not very sensitive indicators. Patient with respiratory muscle weakness or interstitial lung disease, actually they will not become hypoxic until the condition is quite advanced. And therefore, other measures like blood gases, spirometry, and imaging These are required to detect abnormalities in a timely fashion. Muscle power is more commonly graded using the modified MRC scale for manual muscle testing, and we should be aware about this grading system, which ranges from 5, representing normal muscle power, to 0, where there is no muscle contraction. So 4 plus power represents definite but slight weakness. So this is quite useful for tracking weakness, and one should when we are examining the patient, we should grade the power, and because it will be helpful in the subsequent follow-up of the patient. So other type of weaknesses which we should look in this patient is sometimes patient may have a neck weakness or truncal weakness or bulbar weakness, and if these are weaknesses are present, then it represents more diffuse or severe muscle involvement. So remember that clinically, dermatomyositis is differentiated from polymyositis by presence of one or more characteristic cutaneous features. There is also difference between them because of the underlying immune mechanism, antibody association, and biopsy findings. These also distinguish between the two forms of myositis. Gottran sign, as you can see in the second picture there, the Gottran sign, it is actually pathognomic for dermatomyositis, and these rash appears as violaceous roughened papules or muscles, most typically over the extensor metacarpophalangeal joints, but can also occur on the peripheral on the proximal interphalangeal joints, elbows or knees. You can see in the first picture, we can see there is a purple or lilac rash over the eyelids with or without associated swelling, and this is known as the heliotrope rash, and is another classic cutaneous signs of dermatomyositis. Then you can see in the third picture, this appearance is suggestive of mechanic hands, and it refers to painful, roughened erythematous and hyperkeratotic fissuring or cracking of the palmar and lateral aspect of the fingers. So, and remember that signs of active synovitis on joint examination, which includes the joint line tenderness, boginess, effusion, and stress tenderness. Arthralgias, which is pain, or arthritis. Arthritis means pain and swelling. It occurs in around half of the patient with polymyositis. Interstitial lung disease, these are associated with connective tissue disease. Most commonly, there is basal predominant bilateral, and they results in characteristic mid to late fine inspiratory crackles, and this typically associated with pulmonary fibrosis. Remember this, in these patients, a focused cardiac examination assessing for signs of pulmonary hypertension is an important part, and primary pulmonary hypertension may arise particularly in association with scleroderma and mixed connective tissue disease. Patients who have interstitial lung disease also can develop secondary pulmonary hypertension as the disease progresses. And we are all aware about the signs of pulmonary hypertension, which include loud P2, right ventricular heave, tricuspid regurgitation, and in more advanced stages, signs of right heart failure. So this is all about the examination. Then we come to the investigations. So in this patient, the blood test shows an elevated CK of 2300. There is a mild transaminitis on liver function test. Renal function is normal. Inflammatory markers are mildly elevated with a CRP of 28 and ESR 36. ANA is positive at a titer of 1:640. ENA panel also returns positive for the GO1 antibody, with other myositis specific antibodies returning negative. So remember that muscle-related enzymes such as CK and LDH, they are elevated in most cases of inflammatory myositis, and they fluctuate with disease activity. And in rare cases, extra muscular features may be present in the absence of clinical muscle disease. It is called amyopathic dermatomyositis. And CK, may also appear disproportionately low in relation to disease activity if there is a significant muscle atrophy. So patients with myositis may falsely appear to have abnormal liver function because the transaminases like AST, ALT are also muscle-related enzymes. So recognizing this actually prevents any unnecessary investigations into deranged liver function tests. Or conversely, it can prompt testing of the CK in patients who have an unexplained transaminitis. Renal involvement, well, it is not typical for patients with polymyositis or dermatomyositis. However, because there is a possibility of overlap connective tissue disease syndromes, so patients should be screened with renal function, and a urine test should be done for proteinuria and glomerular red cells. So remember that similar to other connective tissue diseases, inflammatory markers may be elevated in line with disease activity in patients with polymyositis, and ANA is present in most patients, around 80% of polymyositis. The ANA, the titers of ANA refers to the actually greatest dilution of serum at which the pattern of immunofluorescence is still seen. In general, the titers more than 1:160 are significant, but we need to interpret it in the clinical context, as the ANA can be positive in otherwise healthy individuals as well. Briefly about the anti-JO1 antibodies. These are the most common types of anti-synthetase antibody, and these antibodies are found in about 15 to 20% of patients with polymyositis. So these are increasing number of antibodies which is associated particularly with inflammatory myositis. These have been identified, and they are routinely being tested to help classify patient into specific phenotypic subsets. And some of these antibodies are known as myositis-associated antibodies, and they are primarily found in the overlap forms of myositis. These includes like anti-PM-SCL antibodies and anti-UN-RNP antibodies, which are present in the mixed connective tissue disease, among others. And there's also a group of myositis-specific antibodies, and which are more specific for polymyositis and dermatomyositis, and are usually, we can say, mutually exclusive. Briefly about EMG. EMG and nerve conduction studies can be performed to help differentiate actually between weakness of different causes, for example, neurological, neuromuscular, or muscular. EMG findings in polymyositis, they may include short duration, may have a polyphasic potentials of low amplitude, with some evidence of membrane irritability. Okay, so EMG is consistent with myositis. An MRI of the thighs show diffuse inflammatory changes bilaterally. A targeted muscular biopsy is performed, and it shows lymphocytic infiltrates and muscle fiber injury, which is consistent with polymyositis. A chest X-ray shows basal, reticular, and ground glass changes, and high-resolution CT confirms a pattern consistent with non-specific interstitial pneumonia. So here is you can see in the chest X-ray, and these are consistent with clinical findings that suggest interstitial lung disease. A non-specific interstitial pneumonia actually refers to a pattern of interstitial lung disease which is characterized by the ground glass opacities and reticulonodular changes, and it is one of the more common patterns seen in association with connective tissue disease. And here you can see in the CT scan, you can appreciate that there is a ground glass appearance. Lung function testing shows a restrictive deficit. So like other causes of interstitial lung disease, a restrictive deficit means reduced forced vital capacity with preserved force expiratory ratio and reduced gas diffusion coefficient would be expected. and actually it assists with determining the severity of lung disease. Okay, so briefly we talk about the management of the patients with polymyositis. So we can divide the management to short term and long term. Remember that these patients must be referred to rheumatology and other relevant specialties as guided by the presence of extramuscular manifestations. We commence high-dose steroids after initial diagnostic workup. We should consider risk associated with weakness such as aspiration, falls, and respiratory failure, and we should monitor for initial response to steroids. One of the important part of the management is we must screen for possible underlying malignancies. So patients with polymyositis should usually be managed by a rheumatologist or other specialist with experience who are experienced in inflammatory myopathies. So patients who have connective tissue disease, they often have multi-system involvement, which requires assessment, and it actually needs coordinated management by various specialties. In case of inflammatory myositis associated with interstitial lung disease, for example, we lung-specific monitoring, we need to do the lung function test, serial imaging, functional tests, and the management like home oxygen, lung transplantation. Maybe all this best achieved if we actually in conjunction with the respiratory unit. Similarly, we need an input from dermatology as well because it assists with refractory cutaneous manifestations of dermatomyositis. Remember that immunosuppression is the mainstay of treatment for polymyositis, and initial treatment is with high dose of oral corticosteroids, usually at a dose of 1 milligram per kg. And sometimes pulse IV methylprednisolone is used for patients who present with severe manifestations. By severe manifestation, I mean dysphagia or respiratory weakness, or the patient having a poor response to oral steroids. For this patient, we can give pulse IV methylprednisolone. So remember that depending on the severity of manifestation and index of suspicion for the diagnosis, the treatment with steroids may commence prior to all the diagnostic information being available, like antibodies, results, or biopsy. They may take several days to return. So patient who have got a possible respiratory muscle involvement should be monitored with regular bedside spirometry to detect deterioration as early as possible. So the response to steroids is actually signified by improved clinical parameters like improving the muscle power and myalgias, and also the biochemical markers. So once we start the steroids, we expect the CK to fall and the inflammatory markers also to fall. And remember, it can take up to 2 to 4 weeks for significant improvement to be realized. So if the patient failed to respond to the initial treatment with steroids, then alternative diagnosis should be excluded and treatment is escalated. So polymyositis and dermatomyositis can occur as a paraneoplastic phenomena. So an underlying malignancy should be considered in every patient. So screening practices actually it vary widely, but should include at least age-appropriate cancer screening tests like mammogram or pap tests, fecal-occult blood tests, and along with the most common underlying cancers are actually adenocarcinomas, but however all types of malignancy may have been reported. In terms of the long-term management, we should wean prednisolone slowly, usually over a period of 9 to 12 months. Consider adding other immunosuppressive agent or commencing the intravenous immunoglobulins to facilitate steroid dose reduction. Monitor for and manage the steroid-related complications. One should be aware that once we start steroid, there are so many complications which can happen. Consider enrollment in a physical therapy or rehabilitation program, and we ensure the patient has regular follow-up, assessing the disease control and complications. So other immunosuppressive drugs are used for refractory diseases as a steroid-sparing agent, and these options include hydroxychloroquine, methotrexate, and azathioprine, mycophenolate, cyclophosphamide, and rituximab. And the choice actually depends on severity of patient disease and involved organs, comorbidities, and patient preference. Briefly about the IV immunoglobulins, they may be used alongside steroids for induction and maintenance of remission in inflammatory myositis, and it's actually a good option in patients with infective complications. IV immunoglobulin also has some efficacy for extramuscular manifestations such as skin disease and lung disease. So once the treatment is commenced and patient is responding, then physical rehabilitation should be encouraged to maximize the functional recovery. And this is particularly important given that because the steroid therapy and hospitalization can contribute to muscle deconditioning. So regular follow-up should be scheduled initially more frequently as disease control is established and then stretched out once remission is achieved. Monitoring for disease activity and treatment complications should form part of each visit. And obviously the manifestations in other organ systems such as interstitial lung disease, it also requires specific monitoring and management. So that's all about the management of the polymyositis and dermatomyositis. And you can just refer to the resource which you are reading, and I hope that this presentation is helpful to you. Okay, so see you in my next presentation.